Hey everyone, welcome back to Treatment of Visual Dysfunction and Visual Impairment. This is part 2 of a 4-part series. In this video, we'll be discussing visuospatial neglect and visual perception. Once again, my name is Jackie Orenda-Weber. I'm an occupational therapy doctoral graduate student from Pacific University, and I am so pleased to be presenting this information to you today. Our specific objective for this lecture is that by the end, you'll be able to discuss visuospatial neglect and visual perception deficits using terminology appropriate for documentation. We'll also continue building on the objectives from last presentation that will carry through the fourth one, including correlate symptoms with common visual dysfunctions associated with acquired brain injury, implement a standardized vision screening in every acquired brain injury evaluation, utilize evidence-based interventions to treat deficits found in vision screenings, and monitor patient progress with appropriate goals, outcome measures, recommendations, and discharge plans. We'll proceed first with visual processing. We'll talk about efferent visual pathways and contrast them with the afferent visual pathways we discussed in the last video. Visual perception, we'll go on to talk about visual dysfunction, specifically visuospatial neglect, agnosia, hallucinations, and more. We'll talk about evidence-based assessment procedures to screen for these dysfunctions and evidence-based techniques to treat them. In our last session, we talked all about the afferent pathway and getting the information through the eye and into the brain. I showed you that picture of the primary visual cortex in the occipital lobe. Here we have a snapshot of all the areas in the brain where that information will go next. Today we're shifting to talking about the efferent system and visual processing. Now, I'm not prepared to talk about each one of these brain sections individually, but the key takeaway is that vision occurs throughout the brain, and vision can be impacted in the majority of brain injuries. It doesn't matter where in the brain a lesion has occurred, most likely vision is going to be impacted. It's not just a consideration with occipital lobe injuries. In the efferent visual system, two broad streams of information leave the striate cortex. We have the ventral stream and the dorsal stream. Information that travels from the primary visual cortex down through the inferior temporal lobe is responsible for determining object recognition, or what an object is. This is how we can differentiate between an apple and a person. This is our central vision, how we determine what something is. Information that travels from the primary visual cortex up through the parietal lobe contributes to sensory motor control and is responsible for motion or spatial components of vision. This is our peripheral vision, how we determine location. Where am I? Where are you? Where is it? And we're using these two pathways all the time. While you're reading the slides and listening to me, or maybe listening to music, chewing gum, eating whatever, you can relax because your peripheral processing tells you that you're upright, there are no approaching threats. But if we just make a jump to think about hemianopsia that we discussed in the last video, how relaxed do you think someone with a visual field cut or hemianopsia is going to be? They're missing half of that survival mode. Treatment for deficits in the efferent visual system broadly are going to help people better answer the questions of what and where to improve comfort and function. If you're in a hospital bed, your brain knows exactly where your body is. A person may not notice their own deficits until movement starts. That's why early mobility is key, one of the many reasons. And you as the therapist might not notice it either. You might think their vision checks out till they start moving, then they're dizzy, they can't keep their focus. So just something to keep in mind. You all already have so much knowledge about visual vestibular integration, so I don't plan to cover this topic in depth, but I do want to include this slide to get us all thinking about the influence of posture and positioning on visual performance. I've heard OTs talk about patients whose visual processing seems okay when they're assessed in bed, but they totally fall apart once you get them up and moving. And that makes a ton of sense because postural control is dependent upon the integration of information from the proprioceptive, vestibular, and visual sensory systems. So we'll just keep in mind that if you have a patient with a vestibular disorder, training on visual processing can support their balance, and vice versa. If you have a patient with a visual processing disorder, training on balance can support their vision. And all of that needs to go together to create an efficient balance system and prevent falls. I'm using the term visual dysfunction here to describe deficits in how the person functions. This is different than the visual impairments we talked about in the last video, which describe how the eye functions. So our definition here is functional vision describes how the person functions and indicates deficits in higher order cerebral mechanisms. And when describing deficits in this context, the term visual dysfunction is used. There are a variety of perceptual deficits that can occur following a neurologic injury. We're focusing, of course, on visual perception rather than all of the other perceptual deficits that could occur. And I'll be talking about these common types of dysfunction, including agnosia, hallucinations, depth perception, visual discrimination, and visual figure ground. Agnosia is the inability to interpret sensations. It's when you can perceive but not understand. And when we're talking about visual agnosia, a person who looks at a bicycle would have no idea what it is, but they might be able to see a wheel or handlebars or a seat. They might be able to recognize it as a bicycle if they touched it. Sometimes visual agnosia is limited to a specific category, like foods or tools. It might be limited to just 2D representations of objects. Maybe a person can recognize real objects just fine, but that picture of a bicycle, they would have no idea. It's been theorized that visual processing happens in 2 stages. First, the brain assembles incoming information into an image. And second, the brain associates that image to past memories to understand its meaning. Appreciative agnosia is an impairment at that first stage, so the person can't reliably name, match, or discriminate visually presented objects. While patients can locate the object and see the parts, they are unable to group the parts together and name the object accurately. With the bicycle example, they might see the wheel and handlebars, but not be able to name the parts to a whole representation of a bicycle. But touching it with their hands, like we talked about, could help them figure it out. Associative agnosia is an impairment at that second stage. The person can't use what they're seeing to access their memories to understand the object's function. In the example of this drawing here, the person could recreate complex images with absolutely no idea of what they were drawing. The visual hallucinations we're talking about here are related to changes in visual function. Studies have found that hallucinations typically start several days after the lesion, then gradually subside within days or weeks, with the end of hallucinations often coinciding with the end of spontaneous increase in intact visual field size. They can happen with low vision, especially macular degeneration, but also after visual field loss. Hallucinations can be formed or unformed with color, or they could be just flashes of light. Usually the content of the hallucinations is not disturbing, but the presence of them might be. Hallucinations usually aren't permanent, and they seem to follow the time course of visual recovery. As you might recall from our last video, spontaneous recovery of visual fields is most likely to occur within the first 90 days, and the same is true of hallucinations. So it's been proposed that the occurrence of visual hallucinations should be closely monitored because it may be the hallmark of self-healing of the visual system. I've been asked what makes visual hallucinations more common in homonymous hemianopsia, and the evidence points to a couple of possible explanations. The first is that the hallucinations may be functional expressions of changes in the excitability of the visual cortex that precede or parallel the return of lost visual functions. So in other words, when hallucinations happen near the border of intact visual field on the affected side, it could mean that recovery is happening there. A second possible explanation is that they are caused by either pathological activation or loss of inhibitory input in neurons bordering the damaged area. This can happen because the brain is used to receiving input on that side of the visual field, and I like to put a little spin on it and just say maybe the brain is doing a bit of sensory seeking. It's difficult to estimate the true prevalence of visual hallucinations post-injury because people generally don't report them. And that's often out of concern that it means they have a mental illness or dementia, or at least that other people will think that's the case. So patients really need to be told that there's a chance they'll experience visual hallucinations following a stroke. Telling the patient in advance will warn them about the potential for hallucinations and reduce the anxiety if they do occur. So if they're having them, it'll normalize it. Like if they're having the hallucinations and they haven't shared that with you, it'll normalize it, let them know that there is a reason and it's okay. And if they haven't experienced them yet, then at least it will reduce their anxiety when it does occur, and maybe they will disclose it to you. And once you've done so, once you have informed them about that potential, just make sure you document it in the chart. Depth perception, or stereopsis, is helpful to move around our environment safely, have accurate visually guided movements, and not spill or drop everything we touch. Three-dimensional shape and distance rely on binocular vision and monocular cues like texture, shading, and perspective. So a monocular cue, for example, you don't need two eyes to know that let's say you're watching this on your laptop. You don't need two eyes to know that your laptop is in front of the wall or whatever is behind it, because the laptop obscures part of that object from your view. That's a monocular cue. Binocular depth perception occurs because our eyes occupy two slightly different positions on our face. As a result, each of our eyes has a slightly different perspective of the world. When our eyes are accurately aligned, our brain can fuse these two different images into one. This horizontal disparity between the two images causes the image to pop into 3D. If you have a patient whose eyes are not aligned, that's a pretty good cue that their depth perception will be compromised. However, it's also possible for clients post-ABI to have fusion, accurate alignment, no double vision, and yet have no depth perception due to cortical damage. Visual form discrimination helps us tell objects apart from one another based on their shape. It's how we can discriminate between an orange ball and an orange. We tend to recognize objects by their shape, so form perception is critical for ADL. This skill is also important for interaction with our environment and visually guided movement. Figure ground perception is the ability to distinguish the figure from the background. It's like finding this stapler here on this cluttered desk. The object of our attention is the foreground. Everything else is the background. This skill is necessary to understand the layout of our environment or to find that stapler on the cluttered desk. The visual system separates figures from the background using features like color, depth, orientation, texture, and motion. For that reason, many scholars consider visual discrimination, that we talked about in the last slide, to be foundational to higher levels of visual perception. Neglect is generally defined as the inability to orient, report, or respond to sensory stimuli in a region of space contralateral to a brain lesion. Because the underlying deficit is one of attention rather than sensation, neglect is considered a dysfunction of cognition. Neglect is a heterogeneous syndrome that can manifest in one or more sensory modalities, distances, and frames of reference. Within the umbrella of visuospatial neglect, we have egocentric neglect and allocentric neglect. Egocentric neglect is where patients fail to attend to the contralesional side of space with reference to their own body midline. Allocentric neglect is where they fail to attend to a contralesional side of an object in focus. And that's what this diagram here is representing. The gradient here at the top describes egocentric neglect, where we're talking about the midline of a person and how the gradient might be very strong here on the ipsilesional side. They can see everything, but then gradually fades toward the contralesional. But I think that this particular diagram here about egocentric neglect is also a good way to think about visuospatial neglect in general, to compare it with a field cut. Because unlike homonymous hemianopsia, which strictly follows the midline, right down the center, a person wouldn't be able to see anything to the contralesional side, visuospatial neglect is characterized by a gradual fading toward that contralesional space. Visuospatial neglect is very common after acquired brain injury, with incidence in 50% of survivors with right-sided brain damage and 30% of those with left-sided brain damage. Patients with this disorder have poorer rehabilitation outcomes. They experience greater safety risk during hospitalization, and they're hospitalized longer compared to those without visuospatial neglect. It's an important predictor of poor functional outcome, right up there with hemiparesis. The brain obviously is complex, and we still don't know exactly why some people with acquired brain injury experience visuospatial neglect and some don't. But studies have shown that visuospatial neglect most commonly occurs after frontoparietal lesions of the right middle cerebral artery. Most spontaneous recovery takes place within 3 months post-stroke, but 30 to 40% of patients with neglect in the subacute phase still have neglect 1 year later. All right, let's go ahead and jump into assessments. As a general rule for all the assessments you'll learn about today, best practice includes ruling out the presence of other conditions by conducting a thorough screening supported by your excellent clinical judgment. Since we're on a roll talking about visuospatial neglect, let's go over those assessments first. Visuospatial neglect, as we discussed, may present with a variety of closely related symptoms. Therefore, it is essential that a battery of tests be used in the assessment of visuospatial neglect. It's not a one test and we can determine that somebody doesn't have it. But recognize that in the real world, in a hospital setting, we're constrained by time and resources. So I've followed the evidence and narrowed the assessments down to those that are most complementary to each other and efficient to administer, balanced with the highest sensitivity. Our first line of defense, so to speak, is the cancellation test. Evidence suggests that this test should be performed with every person with a stroke as soon as they're able to complete it. If we're suspecting visuospatial neglect based on observations or results of the cancellation test, we're going to probe a little further with one or more of the next three: line bisection, figure copying test, and or the baking tray task. Finally, as time allows, we'll use the Catherine-Borgego scale or the mobility assessment course to see how the neglect might impact the patient during daily tasks and be able to assign a score to that. The cancellation test is the most common paper and pencil test for visuospatial neglect. This is the paper test that uses stimuli with a high density presented in an unstructured or random array, interspersed with distractors, and the patient has to cross it out or circle a specific target. Several variations of this test exist, and there really wasn't a clear consensus in the literature on which cancellation test is best. So this QR code will take you to the Bell's test, and I'm highlighting the Bell's test today because it's one of the well-researched tests that happens to be freely available. On the instruction sheet, there is, if you're part of Salem Health, and on the instruction sheets that I've provided, there's scoring info at the bottom, and on the reverse side, there are some norms. So to score this test, you'll be looking at the number of omissions, the the difference between the left and right sides of the page, as well as how long it takes your patient to complete the task. The line bisection test that's a sheet of lines, and it requires the patient to place a mark through the center of each horizontal line. This isn't a standardized assessment, but evidence has shown that with a line length of 20 centimeters or more, a deviation of 6 millimeters or more from the midpoint of the line indicates visuospatial neglect. So remember, this is one of our tests in our second line of defense. Every patient with a stroke should get the cancellation test, and I'd go further and recommend that every patient with an acquired brain injury should get the cancellation test. And then following that, if you still want to probe further and you have some additional questions, this is one of those assessments that you can consider. The figure copying tests rely on your keen observations because it's totally subjective. If you're at Salem Health, there are some examples on the back of your instruction sheet to give you an idea of what to look for and how to document it. This is a widely used assessment technique, but I will say that Mary Warren had some nicely written up instructions in her brain injury visual assessment battery for adults test, by VABA, that I would encourage you to look up. She's posted the manual online for free, and she does sell her assessment materials. So in the baking tray task, patients are asked to arrange items evenly across a tray as if they were buns on a baking tray. Studies have used the cubes, those wooden cubes, and asked them to arrange them on a tray like they were buns or cookies. Patients with visuospatial neglect have been found to demonstrate a clear spatial bias on this task, and will be crowding all of the items onto one side of the tray area. This is another that is not standardized, but studies have demonstrated and indicated that you'll be able to get a pretty good idea. It's not that you need to measure the distance between each of the cubes, but you'll be able to observe, are they neglecting a side of space, or do they have their full unneglected field of view. The mobility assessment course involves higher cognitive and motor demands than other assessments. So it could be a good one to find neglect that isn't always there. It's not there when a person is just seated in a chair or on their bed. There's a little bit of setup involved with this assessment. To prepare for the test, you'll arrange 24 post-it notes on hallway walls at varying heights, half on the left and half on the right. You'll include at least 2 turns and use arrows to indicate the turn so that the patient can direct themselves through the course. Because the patient is walking or propelling themselves down the hallways, this can be considered a multitasking test. The score comes from the number of omissions, and these extra details that I've listed here can help you document your clinical reasoning. The mobility assessment course is a very sensitive test, but it has a greater percentage of false positives than the cancellation test or line bisection test, so something to keep in mind. In scoring, you're going to divide the number of omissions on one side by the number of visible targets. You should not include targets that weren't visible because they were blocked for any reason. Then you'll multiply by the maximum number of targets on that side. So for example, in this case, a person had 4 omissions and one of the 12 targets was not visible during testing. So we're going to do 4 divided by 11 and multiply that by 12. And this comes out to 4.36. And you'll do that for the left side and then for the right side, and you're going to compare the 2 scores to determine the difference. An asymmetry score of 2.3 or more indicates visuospatial neglect. You can scan this QR code to watch a short video of a patient in a hospital completing the mobility assessment course. The Catherine-Berg-Ego scale is a widely used assessment that involves observations of many of the typical ADL that are involved in your initial evaluations anyway. Then the Kessler Foundation Neglect Assessment process is just a tool that you can use to score the CBS and move toward a more objective approach. The Kessler Foundation Neglect Assessment process, or KFNAP, doesn't change the CBS at all. It just makes it so that we can be objective and standardized. I've provided a couple of copies. I have a couple of QR codes to copies on the next slides that you can scan. There are many components involved in the test, so I'm not going to go over all of it in the interest of time. However, I'd encourage you to read through it. This is a really nicely done assessment. Here's a QR code that will take you to the KF-NAP scoring sheet. And here's the full manual. All objective and standardized assessments found in the literature are impractical, unfortunately, in the hospital setting, mainly due to available time. They can take 30 minutes or more, but also because perceptual skills are higher on the pyramid of visual skills. So there's typically time to address. So if we think about that hierarchy of visual skills with acuity and eye movements at the bottom, and then as we move up, visual perception is near that very top. That takes a lot of other foundational components to be accurate. However, some basic visual perception screenings may help inform your discharge recommendations, and they'll definitely support inpatient and outpatient therapy for your clients. A simple, quick screen for visual agnosia is to ask your patient to pick up or point to an object that you name. And you're doing this all the time when you do grooming tasks. If a person can find and pick up their toothbrush when you ask for it, or the hand soap, then you can check this one off your list. If they're having trouble with it, you might downgrade the task by placing several items in a row in front of the patient to remove some of the other stimuli from the equation. Visual agnosia can also present just with faces. So have your patient tell you who's in the room with them. You can use photographs of children or grandchildren, coworkers, friends who aren't present, but it's always best to use the real objects and real people. To assess depth perception functionally, hold out a pen and ask your patient to grab it. You'll be looking for, are they accurate? Do they overshoot? Are they using searching movements? But for an even quicker screen, combine your visual agnosia screen with your depth perception screen. Spread out a few items on the table, name one, and ask them to pick it up. And then bam, 2 observations in one. Keep depth perception in mind when you're observing their function during ADL as well. You might find that they misjudge the location of the toilet seat, or they are they knock their arm on the wall as they're trying to go through. Because visual discrimination is all about telling things apart, you're looking for instances where they have difficulty distinguishing among objects of similar shapes, sizes, and colors. This is a screening that you can probably lump into others, but if you're looking to really isolate visual discrimination, then you can see if they can identify utensils among others in the kitchen. If you spread out the spatula, the fork, the stirring spoon, are they able to go right to the one that you are asking them for? An extreme version of a visual figure ground test would be like a Where's Waldo book or I Spy Hidden Picture book. Functionally, we just want to know if they can find things they're looking for in their environment, not quite to the Waldo level. Can they find the sleeve of their shirt while getting dressed? Can they find the spatula in the drawer when they're cooking an egg? We're starting to get to a point where you can see the overlap in these visual skills probably. So on this third bullet point here, if a person can't find a white towel on their white sheets, what's our problem? What do you think is going on? Is it contrast sensitivity? Is it figure ground? Discrimination? Visual agnosia? Visuospatial neglect? There's a lot of things to consider, so clinical reasoning is really important. As I searched the literature for interventions to address each of these deficits, I focused on interventions that were evidence-based, occupation-centered, efficient for the hospital setting, and sustainable. I separated the perception interventions into rehabilitative or restorative approaches and compensatory or adaptive approaches. These first two, I think, are standard within OT. Real objects are going to be more easily recognizable than drawings or photos, so default to using real objects. When matching, for example, hold a toothbrush and ask them to find theirs, rather than just showing a picture of a toothbrush. Next, progress from simple to complex. The bicycle example from earlier is an example of complex. Start maybe with an apple and work toward bicycle. Lastly, work with similar objects and have the patient notice subtle differences between them. And then on the compensatory side, use touch or your verbal descriptions to help a person identify the objects. Modify their environment with texture or labels, and suggest the use of labels for items at home. To rehabilitate depth perception, provide kinesthetic reinforcement or guiding during activities. And again, for depth perception, use their intact senses to help compensate. Modify the environment with bright color to draw attention to edges, especially for safety concerns. Educate the patient and family about safety concerns before discharge. The best way to practice visual discrimination and rehabilitate it is really just to, practice telling things apart. You're going to do this by having your patient sort objects during their ADL. You can also compensate by removing clutter, keeping organization consistent, and labeling items. With figure ground rehab, we want to increase the clutter to challenge the patient to find items. Unless we're compensating, and then in that case, we'd want to decrease the clutter. It can also be effective to teach the patient to systematically scan each small area carefully to compensate for this deficit. And then, of course, always educate the family about safety and practical concerns before discharge. Earlier, I talked about egocentric and allocentric neglect, and I just want to note that most of the literature on neglect interventions does not distinguish between these two types, and they tend to target egocentric deficits. So we'll just keep that in mind as we're discussing the interventions. Visual scanning training is by far the most well-supported intervention in the literature. Visual scanning training interventions are most effective when they use the principles of anchoring, pacing, density, and feedback. Let's say you're incorporating visual scanning training during ADL. Your patient is looking for their comb to brush their hair. So their grooming items are going to be set up near the sink. You're going to cue them to move their eyes as far to the affected side as they can and tell you what object they see there. That's their anchor. After every visual sweep they make, they're going to come back to that anchor. You're going to have the patient slow down, pace themselves, and look at one object at a time. They can name the object if it helps. When objects are close together, it can be more challenging to find the one you're looking for, so decrease the density by moving things apart a little more. As the patient improves, you can increase the density. And then provide immediate and specific feedback on what you saw their eyes doing, on the strategies you saw them using. And you might have them repeat the same search task a handful of times to practice those scanning movements. Limb activation interventions are so great because you're already doing this for hemiparesis. You can combine multiple intervention techniques here by scanning with movements of a limb on the affected side and even using attention tasks. There was one study that had a button positioned on the affected side during all OT sessions that carried on as usual. The patient had to press the button with the hand on the affected side when it lit up, and then if it wasn't pressed within a few seconds, it would let out a loud buzzing sound. Participants in the study had really good, long-lasting results with their visuospatial neglect in peripersonal space, which is within reaching distance. Other studies had similar findings that using a limb on the affected side decreased visuospatial neglect, at least for the duration of the activity. However, they found that when the patient used both hands together, those effects went away. And so, whenever possible, have the client use the limb on the affected side during scanning movements and really during all aspects of occupational therapy. Researchers in one study attached an overhead horizontal pointer to the patient's torso with a corset or back brace. In this case, I wasn't able to use that photo, and this is just a picture of a chest-mounted phone holder, like a chest-mounted selfie camera, and I modified it to have this little pointer finger here that I thought was descriptive. But the idea is that you require the patient to rotate their entire trunk to point at a target. I think you might be able to DIY some kind of contraption like this, but you're having a person scan and point to objects using their torso instead of their hand. They're using their full body to get that movement to happen. And you want to have them scan, of course, toward their affected side. Neck muscle vibration can be added to your typical OT sessions too, so you can target visuospatial neglect while you're working on reach or grasp or ADL more broadly. I've copy and pasted the technical info from the article that discussed it, and this is from Luout et al. 2006, and they referenced an older article that I wasn't able to read, I didn't have access to. But it's been hypothesized that this technique could be effective for allocentric neglect as well as egocentric neglect. So I highlight this as one of the few interventions in the literature that could support allocentric neglect rehabilitation as well. Video feedback is the last of the best practice interventions for visuospatial neglect. This is to build awareness of the deficit. It's a cognitive training tool. You can use your patient's phone to record them completing a task that has distinct left and right halves. Baking cookies or a pizza are examples, but I'm also thinking shaving the face, brushing the hair, cleaning a table. Maybe you've placed a tape line down the center of that table. When reviewing the video with your patient, ask your patient to describe their performance and allow them to brainstorm possible techniques they could use to improve their performance. Then have them try again and see if their performance improves. This has been demonstrated to be very effective for the alleviation of visuospatial neglect. Here are the image credits, our references. Thank you so much for tuning in. And I'll look forward to seeing you next time.